So, hello, welcome to another episode of Clinical Problem Solvers VMR. And I'm Vini. I'm super excited to welcome you all. And we have a huge team that is helping us to all in the background with all the session. And I want to welcome Kritika that is presenting the case today. Welcome, Kritika. Can you unmute and say hello for us, please?
Hello, everyone. Happy to be presenting the case today.
And other than that, we are having Eugene that is describing how have you been, Eugene?
Hi everyone, I'm Eugene. I'm doing well, by God's grace. A bit cold here, but I'm fine. Yeah.
And finally, we have Julia that is doing teaching points. Welcome, Julia.
Hi everyone, I'm doing 2 points today. Very excited for this case.
And Ravi is the the star of the show. And welcome, Ravi, to another episode. And I'm happy to discuss alongside you today.
Oh, absolutely. No, you're the star. You are joining to discuss today, so I'm very happy to co-pilot this with you. And reflecting on Vinny, he rotated here in December, January. It was very cold, but got to know Vinny. He's such a remarkable human being. I just remember we had a Christmas party, and Vinny stayed back to help clean up along with everybody. No questions asked. You didn't have to ask him. Such a wonderful person. I still appreciate him for doing that because it was a lot of cleaning up over that. So his dancing skills are also spectacular. So do invite him to your next Christmas party. Julia, yes, he will teach you how to dance. All right. Let's get on with the case. Yeah.
Absolutely. Yeah. Gene, feel free to share your screen, and Kritika, we are ready to first aliquot.
Shall I go ahead with the first aliquot?
Yeah, please.
So we had a patient who was a 40-year-old male who presented with chief complaints of fever and shortness of breath for 15 days, generalized body ache for 15 days. And the patient complained of open wound on the anterior aspect of chest from 15 days. And he had burning micturition and loose stools for 3 days. Shall I stop there?
Yeah, all right. That's an excellent start. And for the first aliquot, we have a patient with the chief complaint of fever. And when we pull up the schema for fever, we can have a different approach, and we can divide into some buckets. We can think about infection, we can think about drugs, we can think about something autoimmune, and that's mainly the diagnosis of exclusion, and also some kind of malignancy. And other than that, correlating with we have so far, we have a patient with a subacute history, so it depends on what triggered it and how it progressed through those 15 days. It was like all the characteristics. If the patient had any kind of pain, and if the patient, if the pain is progressive, is decreasing or improving, what triggered it, and so on. So tempo is really important related to the 15 days. And other than that, like the loosest tools makes me think what is the most systems that is affected when we have like fever. So we can have bacteremia, we can have also GI and GU systems that have epithelium. So regards that lung, besides that, we can have lung that is affected, and that fits the chief complaint of shortness of breath that the patient also presents here. And finally, I think that the loosest tool is more for the last 3 days from what I am understanding. And the GU, that is the system that I was missing. So here we can see that the patient mainly have lungs and GU and GI system affected. So I would think that the disease started like kind of slow and progressive, and now the patient would be I would expect that the patient would not be well, would be kind of progressing to shock or sepsis or any kind of what goes in this direction. And yeah, these are my instinct and initial thoughts. What do you have for us, Ravi?
Oh, absolutely nothing much to build on what you've mentioned. You presented a very powerful analysis of the data here. And what I really appreciate is you really haven't jumped into a diagnosis. You're prioritizing the system. So in the early phase of evaluating a case, you're going to listen to the patient and then determine what systems you're going to prioritize. And you nicely explained all the different systems, what is important. And I think the fever and shortness of breath is very important. But this 15 days, you're right, this tempo you mentioned is key here. It's like, why 15 days? Why are you coming? So my question usually would be, what happened over 15 days and why did you present now versus 5 days? So usually we would say like 15 days, the patient would have presented early if this was a very dangerous condition, a very life-threatening condition. But it looks like the patient was like dealing with it, and finally it came to a point where they had to then present. And then the other systems involved now, you got the immune system, you have the shortness of breath, the body aches, and this loose stools could be secondary. So I'm not really going to give much thought at this point, but I can anticipate with loose stools, the patient's going to be volume dehydrated, pre-renal azotemia, maybe then having NAGMA with that as well. So I will look for that and anticipate it in the labs where this point, this wound may be the entry point for a pathogen. And it's on the anterior chest, which is interesting. So I need to get more data regarding what is this wound? How does it look like? Does it look toxic or dangerous? Or is it just a common wound and it might be a detractor and we need to focus back on the lung and the immune system again? So very interesting. So many different things going on with this case. And Kritika, very, very interesting first aliquot. So I'll swing it back to you.
So coming to the history of presenting illness, the fever was a high-grade fever, which was intermittent. It was associated with chills and shortness of breath. Initially, the patient did not have much of an issue, so he could get around with his daily activities. But for the past 2-3 days, it has been exacerbated and it was present even at rest. And the wound on the anterior aspect of the chest, patient mentions that it was initially a blister, which then ruptured to form an ulcer with discharge from the wound. Sorry, I couldn't get the images, but it was more of a superficial one. And the patient had burning micturition for 3 days, and the loose stools was 3 to 4 episodes per day, small volume, watery, yellowish, foul smelling, and non-blood tinged. Review of systems, so there was no associated chest pain, cough, vomiting, any flank pain, or pain abdomen.
So the fever being high grade is a significant, what I like to call a check engine light on the patient. Fever here isn't the primary process, is a signal that something internally in the body is going wrong. If you map the course of fevers, certain conditions can have a significant pattern. Lymphomas can have a pattern, malaria can have a pattern. So here we don't really have a pattern. We just have high grade, which is signaling something going internally wrong in the body. And then chills is associated with this. So chills, then rigors are of particular interest to me because it can help me to make progress with a certain condition called bacteremia. Maybe this infection is not on the surface. Maybe it's in the ulcer and so on, but maybe it's taken time over 15 days to move to the blood and cause sepsis and maybe progress to septic shock eventually. So loose stools could be associated with that because septic shock, it's bacteria riding the HOV lane within the body throughout the arterial system and landing in all sorts of spots, whether it be the spine, the brain, the heart, and any area you can anticipate bacteria could set up shop and cause abscesses and things. The chest wound began as a blister. So certain wounds go through a certain morphological sort of evolution here. So this blister, there was maybe in the epidermis, dermis, there was inflammation, and the epidermis and the stratum corneum like then separated as fluid. So fluid due to inflammation may have then caused that lift up, and eventually it will open and disperse under pressure, and underneath will be disclosed the ulcer that's forming. So the ulcer will be interesting because anytime you have any compromise of the surface epithelium, the dermis, and anything below that, lamina propria and so on, is submucosa, is at jeopardy for infection. You remove the protective layer, and underneath you lack the necessary guard, which is all the cells and so on up there to prevent infection forming. So from the surface, any bacteria that could be riding on the skin, staph, gram-negatives, would just move in and create an infection there. So I'm very suspicious that that could be the port of entry from an infection. So other features, if you think about the blister, like what else could cause a blister? Burns could cause, if this patient had a burn, you can get blisters. This is just one blister. And then also you can have autoimmune phenomena. We tend to get very excited in CPS because we move into the landscape of esoteria, and autoimmune phenomena can precipitate something like this, but it's just one lesion. So it's very early to maybe prioritize that at this point. And again, now these stools are small volume, foul smelling. And it's interesting, like sometimes nurses will tell us foul smelling stool, this is maybe C. diff. But what would cause C. diff in a patient like this if he's taken prior antibiotics, or he has a certain maybe inflammatory bowel disease may also harbor C. diff, but now I think we also have to think about this as well. So I think the broad category infection we're dealing with here, and then any of these are fair game to be causing this patient's presentation. What do you think, Vinny? A lot here. This is a multi-system condition here.
Yeah, absolutely. Just one quick question before I mention my thoughts. Do you think that if there was rigors instead of chills, would be more likely to think about bacteremia, or the clinical picture is very well painted for thinking about it?
Yeah, that's an interesting question. Yeah, rigors definitely. It's interesting. I was once called to the bedside, and they were saying the patient had seizures, and it was rigors actually, because they can be pretty violent appearing sometimes. And that was just after a procedure, a GU procedure, which sometimes you instrument the urethral tract, and you could push up gram-negative rods into the patient's system. So I think even chills can be associated, but I know if we quantitate rigors, I think there was a statistic, your pretest probability can be pretty high with rigors. Chills is sort of the prodrome to that. So I still would use that as a signal for possible infection.
All right. Well, wonderful. And yeah, some quick thoughts that I have is regards the shortness of breath. We always try to differentiate between if this is a shortness of breath initiated by rest or precipitated by exertion, and it was pretty clear that it was precipitated by rest. So that's a point that we need to consider. And other than that, like as you mentioned, the ulcer is the mainly spot that we think about the point of entrance or contamination that can accumulate in the bacteremia and the evolution of possible sepsis. And I am also curious about the past medical history of this patient because if the patient has I don't know, diabetes or immunosuppressive state as his baseline, I think that we will need to think about more I don't know if this is the correct word, but worse bugs, and yeah, that can progress more in a rapid manner, as you suggested, the C. difficile, and there's all kind of others that we can enunciate also. But I will wait for the past medical history and the other data to make some progress in our thoughts. Well, back to you, Mike, to you, Kritika.
Thanks for the great discussion, Dr. Ravi and Vini. So coming to the past medical history, patient is a known case of diabetes mellitus from 6 months, but the patient is not compliant with the treatment, so he's not on any treatment currently. And patient had a history of RTA 5 years back, and he had a left hip dislocation, and he has been having difficulty in walking since then, and he says he walks with the aid of a stick. But when he presented to us, he was on a wheelchair, so we couldn't make that out. And coming to the family history, there was nothing significant, no other significant medical history. And coming to the health-related behaviors, patient had a history of alcohol consumption, about 180 ml of whiskey, 4 to 5 days a week, and a history of smoking with 3 to 4 cigarettes per day, and no other high-risk behaviors.
Do you think that's a good place to stop, Kritika?
Shall I go ahead with the general examination?
No, I think that we can make a brief comments here, and then you can give us the exam. Thank you. So yeah, just what I was thinking is what we can expect in the examination of this patient, and if we're like just simulating, if we are reviewing the chart of this patient before seeing him, I would expect that this patient, as I said, would be very ill and with fever and maybe not able to, I don't know if to communicate very well. And in the lungs, maybe we can find some crickles, or I don't think that wheezes would be a great choice, but we'll see about it. And I don't know if we can see any abdominal pain or any, and also regards the wound, I think that there will be erythema, like the phlogistic signs, calor, rubor, and all the stuff around the area of the wound. And as we discussed, the patient has the diabetes and not on treatment. So I would also be curious about his glycated hemoglobin to see if if this is very high. And other than that, the not currently on meds and health related behaviors, the patient is indeed in alcohol use, or what precipitates a baseline state of inflammation, and maybe can contribute some to the progression of a small infection that started 15 days ago. So any thoughts before we get the exam, Ravi?
Yeah, absolutely wonderful job there, Vinny, was trying to dissect the background of this patient. It's very important to know who you're dealing with. So sometimes we talk about who is the host, right? You nicely defined this host. It's unfortunate. I looked at the RTA, and I think with Dr. Snyder, I was getting confused with renal tubular acidosis, but road traffic accident. So very unfortunate situation with the patient and having this left leg dislocation and having some disability with walking. So functional status is impaired, and diabetes not on treatment. So that is immunocompromised process. Alcohol use does quite a number of variety of things on your system as well. So we don't know the ramifications of alcohol use, long-term alcohol use. And I'm worried about mental health in this patient suffering the disability and then the alcohol, not taking care of himself. But getting to the heart of the matter, now it's kind of time to prioritize. I think we're dealing with three systems here. We have this skin, we have GI, we have lungs, and then we start to think of, well, what are the worst things that can happen and cause conditions in these areas. So one thing that comes to mind, you have an ulcer, staph, strep, toxic shock syndrome. Could be something that can manifest with this. It can cause diarrhea. When you have an infection like this and bacteremia, diarrhea tends to happen with toxicity. So we did early on define this patient like there could be a component of sepsis. And then say another condition you can have with alcohol use, if there's liver cirrhosis, go walking on the beach and so on, or eating raw oysters, Vibrio vulnificus can be something like this. We talked about C. diff can also cause a manifestation like this. Meningococcemia could with this. I don't think I earlier mentioned autoimmune processes, but pemphigus and then secondary infection, sometimes these ulcers, but we have a single ulcer. We're not in the domain of like SGS and toxic epidermal necrolysis, which also can be a severe signal for intrinsic toxicity due to taking medications, patients not taking any medications at this time. So I would kind of keep it confined. The exam would be helpful. How sick is this patient? That would help us to then prioritize which one of those conditions. And I think even if we don't know at this point what likely is going on, what will drive the diagnosis is the diagnostic imaging and also the labs. So if, say, the white count is mega, the X-ray shows ARDS, something's brewing in this patient, which could be septicemia from staph, strep, or any one of those. And then you can then start thinking about more esoteric infections. Any other thoughts, Vinny? Very interesting case so far. I think the next two pieces of data will really help define what's going on.
Yeah, absolutely. We are ready for the next aliquot, Kritika.
So coming to the general physical examination, the vitals patient had a temperature of 100 degree Fahrenheit, a BP of 100 by 60 mmHg, respiratory rate was 40 cycles, and heart rate was 110 beats per minute. Room air saturation was 90% at room air, and GRBS was 166 milligrams per DL. And patient on general examination looked sick, and there was a bilateral pitting edema till the ankle. RS examination, the bilateral vesicular breath sounds were present and fine crepitations in the bilateral mammary, infrascapular and infraaxillary area. Cardiovascular, S1, S2 present and tachycardia was present. And abdominal examination, there was tenderness in the right hypochondrium and the right lumbar region. And neurologically, there were no deficits except that the patient's left lower limb was externally rotated and patient was unable to flex the hip. And on musculoskeletal examination, patient had tenderness in the right arm and bilateral lower limb. There was no discoloration, but there was slight local rise of temperature. Peripheral pulses were felt. Stop there.
Okay, absolutely wonderful. I'll take sort of first stab at this, and the vital signs are very vital, right, in this case. So temperature is not excessive, but is sort of a burgeoning fever there, or sometimes we may call it a low-grade temp. The blood pressure is interesting. It's sort of teetering at the edge. It could be 100/60 and then drop further. So it's not a solid like 140/80, which would be normotensive, 120/80, but this is clearly on the lower end of normal heart rate. There's tachycardia. So you do anticipate with each degree Fahrenheit, there could be an uptick in the heart rate, maybe 8 beats per minute. So the patient is stressed. Respiratory rate is important, 40 breaths per minute. So earlier on, remember we talked about the breathing issue, and with diarrhea, you get acidosis. So the reflex would be at least tachypnea and respiratory alkalosis. So this may not represent pathology within the lung. This could be secondary to a metabolic disturbance. So yes, there is some findings on the pulmonary exam here. I'll let Vinny then elaborate on that. But just the vitals here give you a lot of information. I just love what you mentioned, Kritika. Vital to describe the patient. The patient's looking very sick or toxic. You really will take this seriously then. There's something afoot in this patient, and it's clearly very important to figure out what's going on, because it could be a matter of minutes. A patient like this just could start declining, and you have to switch gears and initiate a rapid response in a patient like this. Vinny, what do you think at this point?
Yeah, wonderful. I think that yeah, the patient is as we discussed before, it's progressing to a very serious systemic condition. Maybe we don't know the source yet, if it is the lungs or the GI or the GU. But anyways, we what we can think about the pulmonary findings is that it is indeed there is a occupying thing in the alveoli and also in the I don't think that also in the upper airways, but in the big like in bronchi and bronchioli also. And I would be curious for a chest X-ray or also if in the physical exam there is like dullness to percussion or difference between the upper and the lower lungs. But I think that for what I remember is just in the lower lungs, lower lungs. And yeah, I think that the abdominal findings could be most related to GI commitment, there's not described any CVA tenderness and CVA tenderness for specifically, but maybe the pain, the lumbar region that is described here could be significant for that. And the hypochondriac is this patient has cystitis and there's pain on palpation when there is palpation in the hypochondriac area. And other than that, I will be curious also if there's any JVD or any commitment to the cardiovascular system as a response to the commitment to the lung system. And the tachycardia is a natural and common response to our body to the presumed infection here. And also, I think that maybe in the labs we would be finding a high WBC, mostly related to neutrophilic predominance due to extended history. But we don't know what we're gonna have. And no, in regards to platelets, you can also have a increasing number of platelets that is reactive to an infection. And I don't have any kind of specific comments to hemoglobin. If the patient looks, there's no comments also if looks hydrated or not. But if the patient looks dehydrated and also has loosened stools for the past 3 days, I would presume that there's a hemo concentration in the hemoglobins. And yeah, these are just the mainly initial thoughts that I have for the exam and the labs. Are you ready for the next aliquot, Ravi?
Yeah, I think I just want to comment, it's great anticipation. I think anticipation is a valuable tool in medicine. You have a hypothesis and you determine, okay, X, Y, and Z may happen. So a lot of times I've gone to complain, I've gone to patient and I look for clues and that will help me to determine what's going on. So what you mentioned there, anticipating the abnormalities in the lab, that's a very powerful learning process, I would say. And it can help you to solve or have your antennas up getting ready for that white count or drop in hemoglobin and so on. And yeah, the chat is interesting in that they're talking about now this musculoskeletal, and now we have actually more data that's now about to take on, or we can add to our cognitive load. So we already have a lot there to contend with, but I think, okay, let's introduce another part of this presentation, which is the tenderness in the hypochondria lumbar region, but more so the left lower extremity extended, unable to flex, tenderness in the arm. So this patient had a motor vehicle accident. What can happen causing these arms and legs? I would kind of like to know if he had a full trauma evaluation. If not, so this is the time we're going to do a full trauma evaluation to see if there's fractures, if there's crush injury, if there's, when you have crush injuries, the rhabdomyolysis that's adding fuel to the fire. and causing downstream effects like acute kidney injury. And then also wondering about compartment syndrome as the pressure, the muscles necrose, and there's all this cellular activity. Some of these compartments, like the forearm, can start to increase in size, become edematous, which the lower extremities were. I think there was edema, if I'm not mistaken. But just these areas of tenderness, is the tenderness due to trauma? Is there ramifications of trauma such as rhabdo, compartment syndrome, fat embolism traveling to the lungs and causing this finding here, and the tachypnea and so on? And the patient's been maybe down for 15 days, resting. Could he have a pulmonary embolism? As we all know, orthopedic patients, trauma patients have a highly inflammatory state and can develop PEs. So there could be multiple level of problem or complications. The primary issue may be infection, and then secondary issues, which is maybe pulmonary embolism or something along those lines. And with the tenderness, what else could you get? It's cellulitis. Maybe there's infection in those extremities. I mean, we clearly know there's an infection going on, right? And now we have to determine where the infection is. Is it hiding in the skin? Is it hiding in the blood? Is it in the respiratory system? There are definitely signals in all these areas, but which one is driving the process is in the front seat, and which one is sitting alongside and then in the back seat as well. So everything is being driven by something, and that's what we have to get to, or we have to identify in this. But again, I think the clue may be in the blood. We're dealing maybe with a toxin, and the toxin could be from anything. Could it have come from the skin, bacterial toxin, endotoxin, and so on, Clostridium, any number of things. My mind is just kind of going dizzy with all of this. So, but let's see if the answer lies, or we can make progress with the CBC in chemistry. Back to you, Kritika.
So coming to the labs, CBC, hemoglobin was 11. WBC count was 19,100, which was predominantly neutrophilic. Platelet was 2.15, and the ESR was 80. And coming to the chemistry, sodium 135, potassium was 4, albumin was 2, and ALP was 294. Total bilirubin was 1.2, and it was direct more than indirect. And SGOT was 69.2 and SGPT 40.2. Creatinine was 0.8, urea 48.7, and INR of 1.5. HbA1c was 11.8, and urine albumin was 1 plus, nil sugars, and ketone bodies was negative. And urine had bacteria present, pus cells of 4 to 8 per HiPA field. And ABG showed type 1 respiratory failure with a PO2 of around 70. And ECG showed sinus tachycardia. USG abdomen and pelvis showed mild splenomegaly and mild right-sided pleural effusion. Chest X-ray showed bilateral non-homogeneous opacities in the lower lung fields and mild bilateral pleural effusion. And 2D echo was done, which was within the normal limits with ejection fraction of around 64%.
Wow, yeah, thank you so much, Kritika. Yeah, there's a lot of data to come in here now. And my I'm just trying to put and organize all the data. But let's take one by one. So we already discussed about what we would have been expecting for WBC, and it is indeed elevated. Hemoglobin, small dilutional here, and other than that, there's no hyponatremia. Potassium looks normal. So there is a high CRP and ESR, and both are the elevated. And the ALT that is elevated here, well, what is make me think about it is there is a accumulation of fluid backboards in the right ventricle, and causing damage to the liver also, or there's indeed a signal of source being the liver. The total bili, Kritika, can you just confirm, is that in the normal range for your lab?
This was normal, yeah. It was slightly in the higher range, but it was normal, more or less.
All right. Yeah. Thank you so much.
Yeah.
And regards the UA, there are some also signs of an infection there. The patient already had the history of brain urination, and now there is high WBC. So what confirms that? What confirms the diagnosis? And I would ask for Ravi to comment on the AVG, and also the EKG is just non-revealing, and we just have the tachycardia that we already discussed about it. The chest X-ray comes with the opacifications, but there's no comments for consolidations from what I remember, and also the pleural effusion. Here, there's bilateral pleural effusion, Kritika. And just remember me, please.
It was a mild pleural effusion bilaterally.
Okay, yeah, thank you. Yeah, so I would think that this is laminar and would I don't know how important this is in the clinical picture. I would value more if there is like a huge consolidation, or there is like all the vascular trauma opacified, and the echo is it's normal. So for regards the now coming back to and relating the thoughts regards the echo and the elevated liver function tests, I would think that due to the fact that the echo is normal, there is no possibility of maybe there's no possibility of fluid accumulating backwards and causing the damage to the liver. So I would prioritize the burn infection, the GU infection here as we have, and also investigating the liver as a source. And what have my attention also is the splenomegaly that I I don't know how to explain and correlate that. Can you shed a light on that, please, Ravi?
Oh, absolutely. Yeah. This, you know, the white cell count has supported our initial hypothesis of infection. Now, fever, white count is a very powerful indicator and will help us make progress. Now we know which domain to prioritize our clinical thinking in, and looking at the VBG, you had mentioned, yeah, we should look at this. Remember earlier on, we anticipated the diarrhea, maybe if it is profuse, 2 to 4 loose stools. And although it says small volume, but you will induce a state of nagma in this case. And the reflex to nagma would be then you have to, the lungs can quickly actually adapt. The kidney takes some while to compensate for for acid-base disturbance, but the lung can immediately kick into action and start compensating. So the reflex will be respiratory alkalosis, which we have a profound respiratory alkalosis, and the CO2 is down to 19. So the patient's working hard, obviously suggested by the respiratory rate, and the patient can only keep that up for a certain period of time. So I do anticipate we're going to run into problems. So we do have to at least intervene and help. This could be easily become a rapid response or a code blue. Definitely we have to calculate the anion gap, because you could have a simultaneously non-ion gap and anion gap. As this patient is running into problems, there could be lactic acidosis or other developments when you run through the Goldmark abbreviation for that. But the PO2 is from blood gas, Kritika, or is also from VBG?
It's from the blood gas.
It's from a blood gas. So PO2 is not bad. Actually, for room air, you would anticipate 80, but I usually use the hard and fast rule. PO2 60 reflects with a O2 saturation pulse ox of 90. And so 70 patients there with is holding steady with room air and doesn't need oxygen at this point, but the SAT is 90%. So I would be careful with this, watch closely, keep the patient on a pulse ox monitor. And with these opacifications in the left lower lung fields, could be something brewing there. There's pleural effusions. Pleural effusions also don't happen overnight. Bilateral could be suggestive of volume issues, could be inflammation, but there's a pacification. Is that pacification due to compressive atelectasis? The lung will compress with pleural effusions, but there's something maybe brewing. Maybe there is bacteria that's riding through the system and then taking up shop in the lung and multiple different areas. Echo is normal, so this likely isn't due to congestive effects in the heart or decompensation in the heart. And so at this point, I think getting data from all the sources we talked about, the UA, what's interesting, white cells, no ketones, and the patient is very uncontrolled. The hemoglobin A1C is very high. So as we obviously know, we anticipated that because patients non-compliant, not taking medications. And so commonly we do see UTI and cellulitis with diabetes. But my thought would be, in the context of all this, is a urinary tract infection the driving process here? Or could there be bacteremia? As you all know, bacteria will float around the system and then will filter through the kidney and give you a pseudo UTI. So the UA will be showing you all this information, but it's stemming from what's in the blood. So you got to be very careful that it's not just UTI, but it's just bacteria filtering through the kidney and showing up as an abnormal UA. But there's bacteremia, of course, that might be there. At this point, yeah, I think I would look for more data from Kritika. Yeah, we were just kind of rolling back to the right-sided thing, finding the splenomegaly and all of that. Yeah, that could be causing this right-sided pain as well, especially with trauma. When you have splenomegaly, EBV, we know you have trauma, you have a splenic rupture, but we're not seeing, there was, I guess, an image showing maybe something, but I didn't see any rupture or signs of hematoma or hemorrhage, sorry, into the peritoneum. Back to you, Kritika.
So the patient was very tachypneic, so he couldn't maintain an oxygen and we had to put him on NIV and the patient was shifted to the ICU. But one thing that was very nagging was that patient was complaining of severe pain in the right arm. So when we examined the patient, we found that he had severe tenderness. So we got an ultrasound of the right arm, which showed a well-defined thick-walled heterogeneously hypoechoic collection with low-level internal echoes and thick internal septations in the intramuscular plane of the posterior lateral compartment of the right arm with surrounding inflammatory changes. And apart from this, because patient also complained of bilateral lower limb pain, we also got a Doppler, which showed no signs of any DVT, but there were diffuse lower limb cellulitis with popliteal intramuscular collection. And in the left lower limb, there was no evidence of DVT again, but diffuse lower limb cellulitis with ill-defined anechoic collection in the left leg and ankle. So there were several intramuscular collections of pus. And we got an NCCT abdomen pelvis because the patient had right upper quadrant pain. And it showed a small focal collection in the right hypochondrium and the lumbar region between the transversus abdominis muscle and the inferolateral surface of the liver. Apart from that, there was avascular necrosis of the left femoral head with the pathological fracture of the neck of femur and posterior-superior dislocation of the distal fracture phalanx. And HRCT thorax was done, which showed multiple patchy areas of consolidation in the bilateral lung fields, predominantly in the bilateral lower lobes, and mild bilateral pleural effusion.
Wow. Yeah.
What do you
Thank you so
think,
much,
Vinny?
Kritika. And yeah, I am thinking let me share with you. So this patient, I mean, it has a high risk for a strep and staph infection, and due to the fact that he presumably got the infection outside of the hospital because he wasn't hospitalized in the previous 15 days. I would prioritize MSSA infection and also strep, and then I think that depends on the idea of every hospital and also per region. But clindamycin could be an option despite being bacteriostatic and not bactericidal, and but also ceftriaxone and other drugs we can have in mind. And if we think in MRSA, we can prioritize vancol or even linezolid. Linezolid being have a such an enormous and great bioavailability and can be given by mouth. And other than that, like just initial things that we would have done for this patient on the ED. I hadn't seen him the first time, like him collecting hemocultures and assessing volume status, and then giving him fluids. Like his blood pressure was very low at that time, and if we think about the sepsis and even septic shock for him, we would prioritize a septic, and this is a distributive shock, so he's very vasodilated. And also regards the imaging here, we can see that there is collections in a lot of regions here. Yeah, and there's also the vascular necrosis of the femoral head. I don't know how to put that through correlating with the clinical picture, or if this is a different entity for him. And the diffuse cellulitis is the left leg cellulitis. I am thinking how we like what about the regards to the temple of the chest wound, and then the cellulitis in the left leg, and like they precipitated around at the same time, or if there is on visual inspection, if there was any difference between the like the erythema and phlogistic signs between those two lesions. And yeah, these are my initial thoughts. Let me think a little bit more and organize then. And what do you have for us, Ravi, please?
I think you covered all the bases. Yeah, infection. What's interesting, just reflecting on the ultrasound when Kritika mentioned hypoechoic. So we know fluid within the body will be anechoic, but when you have pus, pus is not going to give you a totally anechoic signal because fluid will not reflect sound, right? Ultrasound is sound and it goes through. What fluid does, it conducts like an amplifier, conduct the sound across and then reflect from the edge of the fluid, the cavity, or the wall of the cavity. So, but when you have a hypoechoic signal, it's more debris containing fluid. So it could be cellular, it could be clot, it could be fibrin, it could be purulence, it could be just cellular debris. So pus will give you that kind of a signal. So it won't be totally anechoic like urine, like pure blood, like a fluid-filled cavity. So we have that nice clue. I was right when she mentioned that, I was like, this is pus. This has to be, especially within these tissues. There's no business for hypoechoic findings within all of these areas that Kritika had mentioned. So the avascular necrosis, I think trauma is probably the cause. There was no history of steroid use or no predisposing or pre-existing illness that could cause it. So I think there's probably trauma. I doubt there's something nefarious going on in the background, a systemic condition causing this. Autoimmune conditions could cause this too. But I think a lot of this signal is infection, especially the chest, and there's purulence. So again, this is a pole of entry, and the infection has just wreaked havoc on the body and just spread to all other systems. You do have to pay attention, though, to the heart. This is enough time for endocarditis to manifest in endocarditis, as you all know. Usually right-sided would be from injection substance use, left-sided in non-injection substance use disorder. So left side can spread infection to all potential areas, like you see here. And then with the right-sided pain, maybe psoas abscess or any pyomyositis you have to worry about, things like this, infection seeding into all different areas. Any other thoughts, Vinny, before we send the mic back to Kritika?
Just a quick question. Do you have any thoughts what can be causing like multiple collections, as I said, in the chest, in there, in the arm, in the leg, in the located in the abdomen, in the next to the hypochondrium, and because and also, do you think that they appeared at the same time?
Yeah, I think you have to look for seeding, and a process of seeding would be endocarditis. You can get infected debris translocating from the valve to different areas, brain abscess, in the muscles, in the bone, in the spine, anywhere, in the toes, in the legs. So that is a plausible answer for something like this. Could there be also just bacteremia running the highway through the body and just setting up shop? You then have to wonder about what kind of organisms do that. And staph is very fastidious. It will do that. It's very sticky, so it will stick to some of these compartments and cause something as diffuse as this.
All right, well, yeah, thank you so much. We are ready for what do you have for us, Kritika?
So this would be my last aliquot. Because the patient had this multiple pus collections and owing to the sepsis, we started him on empirical antibiotics. Meanwhile, we had sent the cultures. There is a blood, sputum, and then the pus cultures, the swab, everything. So I think that would be the last aliquot, the reports. So pus culture sensitivity from the wound in the chest was positive for Staphylococcus aureus, which was MRSA. And also the pus from the multiple collections in the muscle, that was also positive for MRSA. Blood culture also showed the MRSA. And the urine culture came positive for Klebsiella, which was multi-drug resistant. It had only intermediate sensitivity to fosfomycin. And the sputum culture also showed MRSA.
Wow. Yeah. MRSA just is incredible. Very, very like complex organism and can wreak this much havoc and destruction. And I guess that the time frame, like you mentioned, I what sticks in my mind, Vinny, you mentioned tempo, right? And the time frame, patients sitting home, allowed all of this to just fester and manifest. And being immunocompromised from diabetes, really, there's no defense mechanism that the patient had. So maybe was there a suspicion of endocarditis, Kritika, you think? I know the echo was normal, but sometimes we suspect we do a TE in this case.
Well, we couldn't get the TE done. But the echo showed no vegetations, and I think it didn't fit into the criteria for modified Dukes as well. So,
Okay,
yeah.
awesome. Yeah, you definitely do entertain that. And I think Ravi had mentioned last week also, yeah, something we practice when you're dealing with staph. And when it's very purulent staph, you have to think about MRSA. Usually will produce a lot of purulence in this manner. So you can anticipate MRSA being the organism that's causing this condition. And getting an echo, and if your pretest probability is high, you do need to get a TEE just to rule out endocarditis in such a patient. And you also have to get an infectious disease consult, usually recommended, because sometimes we do miss complications of MRSA, and sometimes they're very difficult to eradicate. So you have to go up the antibiotic chain, which is then vancomycin, daptomycin, ceftaroline, and so on, just to eradicate the infection. Vinny, any reflections? Remarkable case, so much, I guess, manifestation of this MRSA. Incredibly sick patient. And Kritika, amazing presentation, and I just love the management.
Yeah, absolutely. So yeah, thank you, Kritika, for presenting this case for us. And really, what is interesting for me is that like despite being not hospitalized before and on an immunocompromised status per se, patient had a MRSA from the community, so not MSSA from the community, and that's really interesting, and it depends on region by region, but thankfully he had the best approach. And Kritika, how it was taken care of this patient?
Well, the patient was started on meropenem, linezolid, and fosfomycin. He had a long ICU course, but then he recovered, shifted to the wards, and he was discharged. So he did pretty well. But we didn't get back the TE. Even I had this doubt as to can only diabetes contribute to this severe infection and also the multiple focus of abscesses. So I just read up a few articles and it says it is possible, but I would like to hear your ideas if any other workup would be suggested.
Well, amazing. Thank you so much for your reflections. And I think that we're ready for Julia teaching points.
Hello, everyone. So, going to this case, a 40-year-old man with fever, shortness of breath, also an open wound on anterior chest, burning micturition, and loose stools. The first thought is the approach to fever. So we thought about infection versus drugs, autoimmune or malignancy going on. Vinny mentioned that the losing stools plus diarrhea with fever can indicate bacteremia from GI, GU tract, or even the pulmonary system with this shortness of breath. The 15 days indicate a subacute course, so tempo is crucial. Fever also is a sign and not a disease, as Ravi mentioned, so indicates that something is going on within the body. Going on to approach of the chest wound, this indicates inflammation within one of the skin layers and can indicate infections such as staph or strep. And together with loose stools can indicate even more infection, for example, C. diff. The approach to shortness of breath is important to differentiate between at rest or with exercise. And in this patient, this shortness of breath was progressive, so indicates a more severe course. In addition, approach to past medical history, this patient have diabetes and was not on any treatment, so this can contribute to worsening of the infection. Also, the alcohol use could be crucial to know the time versus dose. And this patient could be consumption like some food that could be contaminated, for example, and get a virus infection. Going to physical exam, this patient had an elevated heart rate, elevated respiratory rate that indicates tachypnea, and also the crepitations indicate alveolar compromise. In addition, the tenderness over the abdomen and arms that we saw in the physical exam can indicate fractures, trauma, or even compartment syndrome, embolism, or cellulitis. Going to labs and image, Ravi and Vini had an amazing discussion about elevated liver function tests that can indicate an infection in the liver or a fluid accumulation back in the liver. The EBD shows something that we were expecting, so a respiratory alkalosis. So this patient had an elevated respiratory rate. Bilateral pleural effusions can indicate congestion in this case. And other than that, the elevated hemoglobin A1C, that was something expected because this patient was not compliant to meds. So this can relate to cellulitis, related to diabetes or something like that. About the infection, the bug could be an MSSA because this patient was not hospitalized, but because of diabetes and alcohol, this could be a MRSA and also strep. And Ravi also mentioned the colic signs. So when we have an anechoic, this indicates fluid, for example, urine within the body. On the other hand, hypoechoic sign can indicate a lot of things. For example, cellular clot, fibrin, and pus. And in this case, as we were with a hypoechoic sign, this indicates even more an infection. So in the end, the patient had an AB blood culture that did reveal MRSA. And Ravi also mentioned that when we have very purulent staph, we can also think about MRSA, and it's important in this case to rule out endocarditis. So that's it. Thank you so much for everyone to join in here.
Great teaching points, Julia. That was phenomenal. Thank you. You just hit on all the really important key features of this case. Thank you, Vinny. Also, like Watson had Sherlock, I have you today. So thank you, Sherlock, Vinny, for discussing this case. Wonderful, wonderful discussion.
Oh, thank you so much.
Thank you, everybody, for coming on,
Yeah,
and
thank you so
hope
much.
to see you
Wonderful
tomorrow.
experience.
Yeah. And thank you, Kritika. Fantastic case. Have a great day.
Bye.
Bye.